Hi doctors, welcome to surgery classes of Kerala PSC Assistant Surgeon exam. These classes can be used for UPSC CMS and final year exam preparation also. So straight away into the class, coming to triage, trauma and breast are two important topics for every exams, whether it be Kerala PSC, UPSC CMS, ASI IMO, or for NEET PG. These two sections are very, very important. So, straight away into the class. Coming to triage. What is triage? Since you all have been posted in casualty, you would know what a triage is. Triage is a process of rapidly assessing, sorting, and prioritizing patient based on the severity of the illness. Sorting, assessing, prioritizing patients. It is applied in mass casualties such as disasters, wars, etc. The greatest good for the greatest number is the goal. Optimize allocation of it will help in optimize allocation of limited resources. What are the principles we follow in a triage? We will rapidly assess the patient within 60 seconds, categorize into priority group, and we will be continuously reassessing the patients. So the color coding is a previous year question. So we will categorize the patient into four colors. Red for immediate life threatening but treatable patients. Yellow for delayed serious patients but the patients are stable. Green for minimal or ambulatory patients. Black for dead or expectant patients. Then types of triage. There are three types. Primary triage, which happens on the scene itself. Secondary triage for detailed assessment after stabilization. Tertiary triage is the ongoing triage in wards, ICU, and operation theater. Then coming to START system. START means simple triage and rapid treatment. We will evaluate respiration, perfusion, and mental status of the patient. Then the importance of triage is to ensure maximum survival in mass casualties and to prevent the overwhelming of the healthcare system. The main points to be noted here are the color coding, in which the red for life threatening and for immediate intervention patients, yellow for the light serious but stable patient, green for ambulatory patients, and black for moribund patients. Then coming to TIS. TIS is a score, trauma injury severity score. So, the TIS score predict the mortality in a trauma patient, but on physiological status and anatomical injury. So, the components of TIS are, it's a previous year question. Coming to components of TIS, the components of TIS are revised trauma score, RTS, injury severity score, ISS, and age factor. And we calculate TIS is equal to as RTS plus ISS plus age factor. What are the components of revised trauma score? Revised trauma score is based on GCS, systolic BP, and respiratory rate. Previous year question. GCS, systolic BP, and respiratory rate. Injury severity score is based on abbreviated injury scale, scores of 3 more severe injuries in different body parts. Then the age factor, age greater than or equal to 55 years, adds the weight. Interpretation, higher TIS predicts higher mortality. The use of TIS is trauma triage, prognostication, quality assessment of the trauma care. When we say it is clinically relevant, when the ISS injury severity score is greater than or equal to 16, it defines a major trauma. It's a previous year question. So the next topic is acute pancreatitis. Definition is acute pancreatitis is a sudden inflammatory process of the pancreas with variable peripancreatic autodigestion. Then the etiology can be remembered as I get smashed. So I for idiopathic, G for gallstone, S for steroids, A for alcohol, hypertriglyceridemia, post ERCP pancreatitis, then trauma and infections are the causes of acute pancreatitis, out of which the most common cause of acute pancreatitis is gallstone, which is a previous year question. The second most common is alcohol. Don't make a mistake. The most common cause is always gallstones. Then what is a pathogenesis? It is a premature activation of an enzyme trypsinogen to trypsin within the pancreas, which leads to autodigestion of the pancreatic tissue, which leads to a inflammatory cascade, and then it eventually leads to systemic inflammatory response syndrome. What are the clinical features? How will the patient present with? A case of acute pancreatitis will present with severe epigastric pain radiating to back and nausea, vomiting, fever, tachycardia. On examination, there will be abdominal guarding and distension. Great Turner sign, that is flank ecchymosis, and Cullen sign, periumbilical ecchymosis, will be present in acute pancreatitis. So, the question will be framed like that: a patient, a chronic alcoholic patient, or a patient with past history of gallstone present with severe epigastric pain radiating to back, nausea, vomiting, fever, tachycardia. On examination, there is abdominal guarding and distension, and there is flank ecchymosis, which is known as greater sign, and there is periumbilical ecchymosis known as Cullen sign. So what will we order? We will next do the investigation. In investigation, what will we find? We will find the serum amylase by lipase is greater than 3 times the normal. Lipase is somewhat specific. Then we will order a CT abdomen with contrast, which is the gold standard for assessing the complication due to acute pancreatitis, ultrasound for gallstone. Then we will assess the severity based on Ranson's criteria. The complications of acute pancreatitis are pancreatic necrosis, pseudocyst of pancreas, acute respiratory distress syndrome, sepsis, multiple organ failure, shock, DIC, and acute renal failure. How will you manage the patient? The patient is managed by aggressive IV fluid resuscitation, then oxygen supplementation, ICU care if needed, NPO for bowel rest, nasogastric decompression if severe, early enteral feeding, then analgesia, antibiotics for preventing infection, then ERCP in gallstone pancreatitis with cholangitis. And the prognosis is assessed by some criteria, Ranson's criteria and Bishop score. If it is mild, it resolves with supportive care, and if it is severe, there is high mortality. So, the key points to be remembered as: the most common cause of acute pancreatitis is gallstone, Great Turner, that is flank ecchymosis, and Cullen sign, periumbilical ecchymosis, are seen in acute pancreatitis. CT scan is the gold standard for assessing the complications due to acute pancreatitis, and early enteral feeding is preferred. This is the criteria. Ranson's criteria is the criteria used to assess the severity of acute pancreatitis. What are the criteria? At admission, we will look some criteria. What are the criteria we will look for? We will look for the age of the patient, age greater than 55 years, WBC greater than 16,000 per millimeter cube, blood glucose greater than 200 milligram per deciliter, LDH greater than 350 international unit per liter, AST greater than 250 international unit per liter. Then within 48 hours, we should reassess the patient and look for if there is a hematocrit fall of greater than 10%, blood urea nitrogen rise of greater than 5 milligram per deciliter, serum calcium of less than 8 milligram per deciliter, partial pressure of oxygen less than 60 mm of mercury, base deficit greater than 4 milliequivalents per liter, fluid sequestration of greater than 6 liter. Then how will we interpret it? 0 to 2 is the criteria. There is only 0, 1, 2, 1 or 2 criteria. There will be less than 5% mortality only. If there is greater than or equal to 7 criteria, there is greater than 50% of mortality. For Kerala PSC, you don't have to remember all the parameters. Just remember that a score of greater than or equal to 7 indicates greater than 50% mortality. Okay. Then coming to tension pneumothorax, there won't be a question paper without tension pneumothorax, cardiac tamponade, pleural effusion, phlealges. Some topics are very favorite for the examiners. So tension pneumothorax is such a topic. So tension pneumothorax is a life-threatening condition in which the intrapleural pressure is greater than atmospheric pressure. So the pressure inside the pleura is greater than the atmospheric pressure. So since the pressure inside the pleura is greater than the atmospheric pressure, it will cause a mediastinal shift and severe respiratory compromise. So the mechanism is that it is a one-way valve effect which traps the air in pleural cavity. The intrapleural pressure gradually rises and very suddenly it will rise. So it will lead to mediastinal shift and it will cause vena cava compression, reducing venous return to the heart, and it will lead to shock. So what are the etiology? The etiologies of tension pneumothorax are penetrating or blunt chest trauma, ruptured pulmonary blood, positive pressure ventilation with lung injury, iatrogenic while during central line or biopsy. How will the patient present with? The clinical question will be framed as a patient after suffering penetrating or blunt trauma to the chest presented to the casualty with sudden severe dyspnea, pleuritic pain, tachypnea, tachycardia, hypotension, distended neck veins, trachea on examination. The trachea is deviated to the opposite side and hyperresonant percussion not on the affected side, absent breath sound on affected side, then the patient is in cyanosis or shock. The complications are obstructive shock, respiratory failure, and cardiac arrest if untreated. So, what are the how will it lead to obstructive shock? As said earlier, it will causes venicaval compression, which decreases venous return, and it will lead to shock. So, the type of shock present in tension pneumothorax is obstructive shock. And how will you diagnose this? Don't wait for imaging. Clinically diagnose it. If we take a chest X-ray, there will be absent lung markings and mediastinal shift. And order a chest X-ray only if the patient is stable. Then ultrasound will show absent lung sliding. What is the immediate management? If we are suspecting clinically tension pneumothorax, we should do needle decompression at the second intercostal space in mid clavicular line by a large bore needle. Then, when the patient gets stable, insert an intercostal drain at fifth intercostal mid-axillary line. Then oxygen and resuscitation. The key point is that it should be diagnosed clinically without waiting for imaging. Okay, look into the diagram. The trachea gets shifted, then there is air in the pleural space, so there is a collapsed lung. Okay, so a revision about tension pneumothorax. For tension pneumothorax, the clinical vignette will be formed such as a patient um, who has undergone a penetrating or blunt trauma to the chest suddenly presented to the casualty with sudden severe dyspnea, pain on chest, increased breath sounds, increased respiratory rate, increased heart rate, and hypotension. Then there will be on examination distended neck veins and trachea shifted to the opposite side. On percussion, hyperresonance is heard on affected side, and there is absent breath sound on auscultation, and the patient is in cyanosis and shock. Immediately, what will you do? Immediately, needle decompression is done on the second intercostal space midclavicular line with a large bore needle. So coming to flail chest is also an important topic for every exam. Flail chest is a life-threatening condition where a segment of the chest wall becomes detached due to severe trauma. There will be a paradoxical chest movement, which is the hallmark sign for flail chest. The etiology of flail chest are blunt chest trauma, crush injuries, fall from height, severe direct chest blow. Then, what is the pathophysiology? In flail chest, there will be greater than or equal to 3 consecutive ribs get fractured in greater than or equal to 2 places each. The fractured segment become free floating, and in inspiration the fractured segment will move inwards, and in expiration they will move outward, which is a paradoxical movement to normal. So there is a paradoxical chest movement in flail chest. Lung contusion is a major cause of hypoxia in flail chest. The patient will present with severe chest pain, respiratory distress, hypoxia. Paradoxical chest movement is the classic sign. Then there will be crepitus over fractured ribs. Subcutaneous emphysema will be present. What are the complications of flail chest? The pulmonary contusion, pneumothorax, hemothorax, respiratory failure, and shock are the complication. How will you diagnose? Clinical examination, we can assess the paradoxical movement of the chest. In chest X-ray, there will be rib fracture and lung contusion. CT chest will give us a detailed evaluation. How will you manage the patient? Oxygen therapy and pain control by epidural or intercostal block. Stabilize the flial segment by internal fixation or external stabilization. Mechanical ventilation for respiratory failure. Intercostal drain if pneumothorax or hemothorax is present. Surgical rib fixation in severe cases. So the key points to remember in flial chest are paradoxical movement, pulmonary contusion is the main cause of hypoxia. Look the figure. There are uh, three or more two three or more areas is fractured in two or more sides. Okay, so look into the diagram. You can see three ribs are fractured. Three consecutive ribs are fractured in two or more places. So this is a flial chest X-ray. Then coming to compartment syndrome. Compartment syndrome is also a very important topic. In Kerala PSC question paper, it is recurrently asked in every question paper. Okay. Then compartment syndrome is increased pressure within a closed osteophyseal compartment compromising the nerve supply and the blood supply of that compartment. It commonly affects the legs and in leg anterior compartment and forearm. Then, what are the etiologies of compartment syndrome? Trauma, it can be due to fracture or crush injury, tight cast, splints, bandages, reperfusion after ischemia, snake bites, burn, excessive exercise also can cause compartment syndrome. What is the pathophysiology? There will be a raised intracompartmental pressure which is greater than the capillary perfusion pressure. Muscle and nerve ischemia occur very rapidly, which eventually lead to necrosis and permanent contractures if untreated. What are the clinical features? Remember, the clinical features are 6 P's: pain, pallor, pain out of proportion, pain on passive stretch, which is the very sensitive sign, then paresthesia, pallor, pulselessness, paralysis. Pain out of proportion, pain on passive stretch, paresthesia, pallor, pulselessness, and paralysis. Then how will you diagnose? Primarily, we will diagnose by clinically only. Then the compartment pressure. On examination, the compartment pressure will be greater than 30 mm of mercury confirms the diagnosis. It is a previous year question. Do not delay fasciotomy for imaging. Then the management, remove the tie dressing, splints, cast, keep the limb at heart level, not elevated. Urgent fasciotomy is the definitive treatment. Aggressive fluid resuscitation should be given, debridement of necrotic muscle if delayed. The complications are Volkmann's ischemic contracture, which is described in orthopedics class. Then nerve damage will be there, fibrosis, chronic pain, muscle necrosis, rhabdomyolysis, and renal failure. So, compartment syndrome can even lead to renal failure and rhabdomyolysis. Then the key points are there will be a pain on passive stretch, which is the most earliest and most reliable sign of compartment syndrome. Fasciotomy should not be delayed once the diagnosis is suspected. Okay. It will lead to compromisation of circulation and function of tissue. Then in compartment syndrome, intracompartmental pressure will be greater than 30 mm of mercury. Then coming to head injury, very, very, very important in every question paper, whether it is UPSC, NEET, PG or Kerala PSC, there will be a question from head injury. First coming to extradural hemorrhage. What is extradural hemorrhage? Look at the diagram. It is hemorrhage between the skull and dura mater due to arterial bleed, and it is often due to middle meningeal artery. So it is the collection of blood between skull and dura mater. It is due to arterial bleed. The artery mainly involved is middle meningeal artery. What are the etiology? Temporal or parietal skull fracture in pterion region. Middle meningeal artery is the most common artery injured. Venous sinus tears will be also an etiology, but it's a rare cause. Then it will mainly occur in young adult and adolescents due to trauma, and it is rare in elderly due to tightly adherent dura. Pathophysiology: high pressure arterial bleed will lead to rapid expansion and midline shift and raised intracranial pressure. The patient will have a lucid interval, which is a classic feature of extradural hemorrhage. What is lucid interval? It is a brief unconsciousness during that time, and the patient will recover, and again the patient will get deteriorated. This is known as lucid interval. There will be severe headache, vomiting, ipsilateral dilated pupil due to third nerve palsy due to this midline shift and all. Then there will be contralateral hemiparesis. So there will be ipsilateral dilated pupil with contralateral hemiparesis. Then the signs will be on eye, there will be papilledema, Cushing's triad will be present. What is Cushing's triad? Bradycardia, hypertension, irregular respiration. Then in radiology, CT, we will order for a CT. There will be a biconvex lens-shaped hyperdense lesion not crossing the suture line. Look into the diagram. How will you remember? EDH. Remember as idli, EE, idli. So it will be idli shaped or biconvex. Lens shaped, hyperdense, and it will not cross suture lines. Then the differential diagnosis is rest of the hemorrhages such as subdural hemorrhage and intracerebral bleed. What is the treatment? The treatment portion is very important. Emergency craniotomy and evacuation. When? If volume is greater than 30 ml, if there is a Glasgow coma scale drop and midline shift, we will do surgery. And conservative, if it is small, GCS is greater than 8, and if there is only minimal shift, we can conservatively manage the patient. But when the volume is greater than 30 ml, GCS drop is there and midline shift is there, we will go for emergency craniotomy and evacuation. Prognosis is excellent if treated early, and mortality increases if diagnosis is delayed. The complications are very important. It will lead to brain herniation, then persistent neurological deficit. So, the clinical vignette will be formed as a young adult after an RTI presented with a severe headache and vomiting. The bystander gave a history that and there was a brief unconsciousness and the patient recovered, and there was a sudden deterioration there. On examination, there will be ipsilateral dilated pupil and contralateral hemiparesis. On examination of eye, there will be papilledema. On vitals examination, there will be bradycardia, hypertension, irregular respiration, which is known as Cushing's triad. Then we will order for a CT scan. In CT scan, we will see an idli shaped or biconvex lens shaped hyperdense lesion, which is not crossing the suture lines. Then we will look for the volume. If the volume is greater than 30 ml and if GCS drop is there and midline shift is there, we will take the patient for emergency craniotomy and evacuation to prevent complications such as brain herniation, death, and persistent neurological deficit. Then coming to subdural hemorrhage. So, subdural hemorrhage is the collection of the blood between dura mater and arachnoid mater, and it is usually venous bleed from bridging vein. Extradural hemorrhage was an arterial bleed from middle meningeal artery, but subdural hemorrhage is a venous bleed from bridging veins. The etiology is head trauma, acceleration deceleration injury. Anticoagulant therapy can lead to subdural hemorrhage, alcoholism, and in elderly also, subdural hemorrhage is found. Epidemiology, elderly and infants are more prone due to brain atrophy and weak bridging veins. So, there will be venous bleed on trauma. The pathophysiology is when the venous bleed is there, there will be gradual accumulation. Accumulation of the blood lead to increased intracranial pressure and brain compression, which will lead to signs and symptoms. So the patient will present with gradual onset headache, confusion, focal neurological deficit, progressive loss of consciousness, no lucid interval in subdural hemorrhage as extradural hemorrhage. Okay, then there is three types: acute, subacute, chronic. In acute, the symptom will be less than 72 hours post injury. Subacute means symptoms for 4 to 21 days. Chronic if the symptoms are greater than 21 days persisting. Then we will order a CT scan where we will find a crescent shaped hyperdensity crossing the suture lines. So, subdural crosses suture. Remember like that. Then the differential diagnosis is rest of the hemorrhages such as extradural hemorrhage and intracerebral bleed. The treatment is Burr Hall drainage or craniotomy if symptomatic or the bleed is large, conservative if small or asymptomatic. Prognosis, it varies. Chronic STH have a good prognosis if treated early. Complications same as EDH, brain herniation, seizures, neurological deficit. So This is the diagram, a subdural hemorrhage. The blood is getting accumulated between the dura mater and the arachnoid matter. On CT scan, we will see a crescent-shaped hyperdensitivity crossing the suture lines. The treatment is bulb hole drainage or craniotomy. Then coming to pseudocyst of pancreas, it's a complication of acute pancreatitis and it's a recurrent question in Kerala PSC question paper. Okay, what is pseudocyst of pancreas? It is a localized collection of pancreatic fluid which is surrounded by a fibrous wall without epithelium. This definition is very important. It is a collection of pancreatic fluid surrounded by a fibrous wall without epithelium. It develops typically 4 plus weeks after acute pancreatitis or pancreatic trauma. The etiologies of pseudocyst of pancreas are acute or chronic pancreatitis, pancreatic trauma, pancreatic duct obstruction, and alcohol abuse. The pathophysiology, there the duct will be disrupted and which leads to pancreatic enzyme leakage and collection of pancreatic fluid around which the fibrous wall will form over the time and there will be no true epithelial lining. The patient will present with persistent epigastric pain and fullness, palpable epigastric mass, which is a classic sign of cirrhosis of pancreas, early satiety, nausea, vomiting, jaundice. If the cirrhosis compresses the bile duct, then there will be history of recent pancreatitis or trauma. Diagnosis: ultrasound will show cystic lesion. CT scan is the gold standard diagnosis for complications associated with acute pancreatitis. So, the gold standard investigation to assess the complication of pancreatitis is CT scan. MRI or MRCP for ductal, assessing the ductal anatomy. The complications are infection or abscess formation, hemorrhage into the cyst from vessel erosion, rupture into the peritoneal cavity or GI tract, obstruction of the bile duct or duodenum, pseudoaneurysm formation. So these are the complications. Remember the complications. Okay. Management is very, very important. When will you do surgery for pseudocystic of pancreas? If it is less than 6 centimeter and less than 6 weeks and asymptomatic, just observe the patient. Drainage is required if the pseudocyst is greater than 6 centimeter, greater than 6 weeks or symptomatic. We will do endoscopic, percutaneous or surgical drainage. Okay. Then the key points to remember is it's a collection of pancreatic fluid in a fibrous wall without epithelium. Wait and watch approach for small early cyst, and complications are infection or abscess formation, hemorrhage into the cyst from vessel erosion, rupture into peritoneal cavity or GI tract, obstruction of bile duct or duodenum, pseudoaneurysm formation, and the patient will mainly present with early satiety, nausea, vomiting, and palpable epigastric mass after a recent history of pancreatitis or trauma. Then coming to carcinoma breast. So next topic is CA breast. CA breast is a very vast topic. I have tried my maximum to concise the note as far as possible. So into CA breast. So first I will start with anatomy. The breast extends from second to sixth rib, sternum to mid-axillary line. The axillary tail of Spence extends to axilla. The blood supply of breast is internal thoracic artery, lateral thoracic artery, and intercostal artery. Lymph drainage is to axillary nodes, which are most important, and internal mammary nodes. Then the nerve supply is given by 4 to 6 intercostal nerves, and the Cooper's ligaments gives structural support to breast. So, carcinoma breast is a malignant tumor arising from the breast epithelium. Commonly, it can be ductal or lobular carcinoma. The risk factors are female gender, increasing age, early menarche, late menopause, nulliparity, family history, BRCA1 or 2 mutations, hormone replacement therapy, obesity, and alcohol. The pathology: invasive ductal carcinoma is the most common type, which is a previous year question. What is the most common type of CA breast? It is invasive ductal carcinoma. Then there are invasive lobular carcinoma, ductal carcinoma in situ, lobular carcinoma in situ, and Paget's disease of nipple. Then the clinical features, the patient will present with a painless breast lump, which is a classical sign. The breast lump will be painless. There will be nipple retraction, discharge from the nipple, skin dimpling, purity orange appearance, which is due to skin edema due to subdermal lymphatic obstruction, then axillary lymphadenopathy, ulceration or fungation in advanced cases of CA breast. Then there is a TNM staging, which I will be discussing later. Then when a patient comes with a painless breast lump, what will you do next? We should assess triple. There is an assessment known as triple assessment. First we should take history, then we should examine the patient, then we will order an imaging, whether it will be mammography or UST, then we will order an FNAC or core biopsy. Then in mammography, if it is carcinoma, what are the findings? There will be speculated mass and microcalcification in mammography. In When we order an MRI breast, we can see whether the CA breast is multifocal or multicentric, and hormone receptor testing such as ER, PR, HER2 test are also done. Then treatment, the surgery is modified radical mastectomy. Then there is another surgery known as breast conservation surgery, in which the lumpectomy is done along with radiotherapy, sentinel lymph node biopsy. Then there are radiotherapy after breast conservation surgery, or in high risk MRM cases, then we can go for chemotherapy, neoadjuvant or adjuvant based on the stages. Then there are hormonal therapy. Hormonal therapy is by tamoxifen and aromatase inhibitors. Then targeted therapy such as trastuzumab. Then the complication of surgery is most common complication is seroma. Then there will be lymphedema of the arm, and there will be recurrence and metastasis to bone, lung, liver, and brain. Then screening and prevention. How can you screen? Mammography every 2 years from age 50. Then self breast examination monthly. Then genetic counseling in BRCA mutation carriers. What are the prognostic factors in CA breast? Tumor size, lymph node involvement. It is the most important prognostic factor for CA breast is lymph node status, then histological grade, receptor status, HER2 new positivity, Ki67 index are the other prognostic factors. So the key points to remember is that axillary node status is the most important prognostic factor. The most common type is invasive ductal carcinoma, and triple assessment is the gold standard for diagnosis. Then coming to some anatomy, dimpling in CA breast is due to tethering of the Cooper's ligament by inverse carcinoma. Remember as CD, Cooper's ligament dimpling. Puckering is due to fibrosis and traction on breast tissue or skin by underlying malignancy. Puckering, fibrosis and traction of the breast tissue by underlying malignancy. Purity orange, which is an important previous year question, it is due to lymphatic obstruction by carcinoma causing skin edema around the hair follicles. Then coming to TNM staging of breast carcinoma, which is very very important. Then there is T means tumor size, N means lymph node, and M means metastasis. So TIS means in situ carcinoma in situ. T1 is less than 2 centimeter, T2 2 to 5 centimeter, T3 greater than 5 centimeter. Then the T4 staging is recurrently asked in every question paper. So T4 means any size with the chest wall or skin involvement. So T4A is chest wall involvement, T4B is skin changes such as ulceration and nodules, T4C is both chest wall and skin involvement, T4D is inflammatory carcinoma. Then coming to knots, N0 means no knots, N1, 1 eye. Okay, remember as 1 for eye. Movable ipsilateral axillary knot. N2, fixed mated axillary knots or internal mammary knots. Then N3 supraclavicular knots, N3A infraclavicular knots, N3B internal mammary and axillary knot, N3C supraclavicular knot. Then M0 no distant metastasis, M1 distant metastasis present. Then coming to modified radical mastectomy type and structure preserved. In Petty's MRM, modified radical mastectomy, pectoralis major is preserved. In Oceanclaw's MRM, both pectoralis major and minor is preserved. The preserved nerves in both the surgeries are thoracodorsal nerve and long thoracic nerves are preserved. Then MRM means a simple mastectomy with axillary clearance is known as modified radical mastectomy. Then coming to breast conservation surgery, in which all patient would we do breast conservation surgery? In early breast cancer, we can do breast conservation surgery if the lesion is solitary and the patient preference is there, and if there are no contraindications, we can go for breast conservation surgery. The questions are asked from contraindications of breast conservation surgery. The contraindications are multicentric disease, diffuse microcalcification, prior radiotherapy, large tumor breast ratio are the contraindications for breast conservation surgery. Then during MRM, if there is an injury to long thoracic nerve, it will affect serratus anterior muscle, which leads to winging of scapula. Then the next topic is breast abscess. Breast abscess is defined as a localized collection of pus within the breast tissue. It commonly occurs in lactating women. This lactational abscess, the most common organism involved is Staph aureus. The feeding mother will present with a painful, tender, red swelling with fever and fluctuation in advanced cases. We will order the ultrasound, breast and pus culture. Management is incision and drainage, and the antibiotic used is flucloxacillin, and continued breastfeeding is advised. Then the complications are recurrent breast abscess, fistula formation, and scarring. So the PYQ areas are lactational abscess the most common. IND is the treatment of choice. The antibiotics used is flucloxacillin. Then coming to fibroadenoma or breast mouse, fibroadenoma is a benign fibroepithelial breast tumor which is commonly seen in young women. So the young woman will present with a paintless lump. It can be mostly fibroadenoma. It is the most common benign breast tumor and it is seen in age group 15 to 30 years, and the patient will present with painless, mobile, firm. So it is known as breast mouse lump and it can be often multiple or bilateral. Then we will order an USG then FNAC, and we will look for the BIRATS triad and core biopsy if it is uncertain. Then the management is if the fibroadenoma is less than 2 centimeter, observation is needed and surgical excision is done if the fibroadenoma is greater than 2 centimeter or symptomatic. The variants of fibroadenoma are giant fibroadenoma, which is greater than 5 centimeter, and juvenile fibroadenoma. Complication, they have rare malignant transformation. So the area to focus is that fibroadenoma is the most common benign breast tumor, also known as breast mouse, due to its mobility. Then coming to invasive ductal carcinoma. Invasive ductal carcinoma is the most common breast cancer arising from ductal epithelium. It accounts for 70 to 80% of all the breast cancer. The risk factor for invasive ductal carcinoma is prolonged estrogen exposure, family history, BRCA mutation. So in BRCA mutation, the carcinoma found is invasive ductal carcinoma. The patient will present with painless, hard, irregular lump with nipple retraction and pudgy orange skin changes. So it is invasive. Then the investigations used are mammography, ultrasound, FNAC or core biopsy for confirmation. The treatment is surgery, breast conservation surgery or mastectomy, then chemoradiation therapy, hormonal therapy. Prognosis depends upon the stage, lymph node status, and the receptor status. So, the most common breast carcinoma is invasive ductal carcinoma. Pudgy orange feature is found in invasive ductal carcinoma. Axillary nodes are the common sites of metastasis. Then coming to BIRATS. BIRATS means breast imaging, reporting, and data system. After FNAC and USG, they will be giving a BIRAT staging. So BIRAT staging is 0 is incomplete. So we should do additional imaging for the follow-ups. And BIRATS 1 mean it is negative, so routine screening is recommended for the patient. BIRATS 2 is benign finding but continue the routine follow up. 3 is probably benign, that is less than 2% chance of malignancy and short term follow up is needed. 4A is low suspicion, 2 to 10% risk, biopsy is recommended. 4B, intermediate suspicion, 10 to 50% risk of malignancy, so biopsy is recommended. 4C is moderate concern, 50 to 95% risk, so biopsy is strongly recommended. When the BIRAT stage comes to 5, it is highly suspicious of carcinoma. There is greater than 95% risk of malignancy, so appropriate action should be taken. BIRAT 6 is non-malignancy and it is biopsy proven malignancy. Then coming to invasive lobular carcinoma. Invasive lobular carcinoma is the second most common type of invasive breast carcinoma. Invasive ductal carcinoma was the most common. Invasive lobular carcinoma is the second most common. They arises from lobules, so it is known as invasive lobular carcinoma. It accounts for 10 to 15% of invasive breast cancers. The risk factors are they are similar to ductal carcinoma, and this is also linked with BRCA mutation, prolonged estrogen exposure. In histopathology, this is a previous year question. Indian file pattern is seen in invasive lobular carcinoma. Why? It is due to loss of E gathering, and signet ring cells may be present in invasive lobular carcinoma. The clinical features are it is poorly defined, diffuse thickening will be present, and it can be often bilateral or and multicentric. So the investigations are mammography, which is less sensitive, and MRI is preferred to know the extent in invasive lobular carcinoma. It has a higher incidence of bilaterality. GI involvement, ovary, meninges, metastasis are more common. So the management is breast conservation surgery or mastectomy, axillary staging, hormonal therapy if ERPR is positive. Then the area to be focused is Indian file pattern is seen in histopathology of invasive lobular carcinoma. There is loss of E gathering. Bilaterality is seen in this carcinoma and it will be multicentric. Then coming to molecular type of breast carcinoma, which is very important and asked in Kerala PSC recurrently. So there are four types mainly: luminal A, luminal B, HER2 enriched, triple negative or basal-like. Luminal A, ER positive, PR positive, HER2 negative, low Ki67 proliferation index, and luminal A has the best prognosis, and hormone therapy has a higher response towards luminal A. Then luminal B, ER positive, PR positive, HER2 negative, but high Ki67 index and worse prognosis than luminal A. HER2 enriched, ER negative, PR negative, but HER2 positive. It is an aggressive tumor and it responds to trastuzumab. Triple negative or basal-like, in which ER negative, PR negative, HER2 negative associated with BRCA1, and it has the worst prognosis. Okay. Then coming to pages of the breast. Pages is an eczematous lesion of the nipple and areola due to underlying ductal carcinoma. So, due to underlying ductal carcinoma, there will be an eczematous lesion of the nipple and areola, and this is known as Paget's disease. It is due to malignant ductal cells migrate through lactiferous duct to the nipple epidermis. So, this ductal carcinoma malignant cells will travel through lactiferous duct to nipple epidermis and causes eczematous lesion of the nipple and areola. It's a rare condition strongly associated with ductal carcinoma in situ or invasive carcinoma. There will be erythema of the nipple, ulceration and itching of the nipple, scaling and eczema-like changes of the nipple discharge or inversion may be present. Diagnosis is by the biopsy of nipple lesion and it will show malignant cells in the epidermis. The differential diagnoses are eczema, dermatitis and psoriasis. The treatment is same as underlying carcinoma. Then the prognosis depends upon the presence of the underlying carcinoma. Paget's disease is a hallmark for underlying ductal carcinoma. Then coming to types of nipple discharge. If it is bloody discharge, the cause is intraductal papilloma, previous year question. If it is a serous discharge, fibrocystic change. If it is a purulent discharge, it can be breast abscess or mastitis. If it is greenish or brown discharge, it can be ductectasia. These highlighted points are asked in previous year questions. Then coming to Glasgow Coma Scale, which is a very important topic. Surely there will be a question every year from Glasgow Coma Scale. So there are three components: eye opening, verbal response, motor response. Remember as E4, V5, M6. So there is scoring for eye opening. Eye opening such as spontaneous 4, speech 3, to pain 2, no response 1. So how can you remember it? Sally's vision proves natural. So eye opening spontaneously 4. To speech, eye opening to speech 3. Eye opening to pain 2 and no response 1. Okay. Then coming to verbal response, and the mnemonic is our clever interns cries naturally. O, oriented. C, confused. 4, inappropriate words. 3, incomprehensible sounds. 2, no response. 1. Then motor response, the mnemonic is our lions walk fearlessly everywhere now. So obeys command. 6, localizes pain. 5, withdraws to pain. 4, abnormal flexion, that is decorticate. 3, abnormal extension. 2, no response. 1. So you have to mug it up. I have given the mnemonic in the notes, so please download the notes and study. Okay, then now an addition is there: pupil reactivity score. If the both pupils react, the score will be 2. One pupil is unreactive, the score, both pupils react, the score will be 0. Remember, as both has O, so 0. One pupil unreactive, 1. Both pupils unreactive, 2. So how can you calculate the final GCS score? The final GCS score will be calculated as eye component, verbal component, motor component minus pupil component. Then the minimum GCS score will be 3. Even though the question says that a patient after a head trauma, after an RTA accident, comes with no response in eye, no verbal response, and no motor response, what will be the GCS score? The option will given as A 0, 2, 3, C as 15, 11, or some value. Always mark 3 as answer because the lowest GCS score is 3, not 0. Okay, then if it is not measurable, NT can be written. Okay, it was also asked in Kerala PSC question paper. Not accessible, not testable, like NT. So if the eye opening cannot be tested, ENT, you can write like that. Okay, then coming to pleomorphic adenoma and Frey's syndrome. Then pleomorphic adenoma, this is chapter on salivary gland. Okay, so pleomorphic adenoma is the most common benign salivary gland tumor. It affects the parotid gland and can occur in submandibular or minor salivary glands too. Pleomorphic means there are more than two morphology, think like that. So it is a mixture of epithelial and mesenchymal. Myxoid or chondroid elements will be there. It will be a slow growing, firm, painless parotid swelling, but it can undergo malignant transformation to mucoepidermoid carcinoma. So the treatment will be superficial or total parotidectomy. Enucleation is avoided due to recurrence risk. So we will do mostly total parotidectomy. Then the most common salivary gland tumor is pleomorphic adenoma. Recurrence is there if not excised completely. Then coming to Frey's syndrome, it's a previous year question paper. Uh, Previous year question. So the definition is Frey's syndrome is gestatory sweating over the parotid region due to injury to auriculotemporal nerve after parotidectomy. What will happen? The parasympathetic fibers are misdirected to sweat glands. So there will be sweating after parotidectomy over the gestatory area. The patient will present with sweating, flushing, and warmth over the parotid area while eating. So sweat is coming, so we can do minor starch iodine test. Then the treatment is botulinum toxin injection, tympanic neurectomy. So this is seen after parotidectomy surgery. So minus iodine starch iodine test is the test for diagnosis of Frey syndrome. Then coming to tumor lysis syndrome, this is also a very important question. It's a previous year question. Tumor lysis syndrome is an oncological emergency due to rapid lysis of tumor cells releasing intracellular contents. So, it is an oncological emergency due to rapid lysis of tumor cells releasing intracellular contents of the tumor. It is seen most commonly after chemotherapy for high grade lymphomas and leukemia. Then the pathophysiology is massive tumor cell breakdown will be there. So, since the cells are getting breakdown, surely there will be hyperuricemia, hyperkalemia, hyperphosphatemia, but hypocalcemia. This is the point to remember. Hyperuricemia, hyperkalemia, hyperphosphatemia, but there will be hypocalcemia. The clinical feature after chemotherapy, the patient will present with nausea, vomiting, arrhythmia, seizures, and renal failure. Think about tumor lysis syndrome. The investigation is to evaluate hyperuricemia, send uric acid, potassium, phosphate, calcium, and take an ECG to look for any ECG changes. The risk factors are there will be high tumor burden and high LDH level. Prevention is by hydration, allopurinol, and RAS uricase. So, once again, I will tell how to approach when a patient comes with a breast lump. When a patient comes with complaints of lump in the breast, first do a clinical examination, and it is examined using our flat surface of the fingers, then in sitting and in supine position, and assess whether there is a lump present or not. If the lump is present or not, go for non-invasive investigations such as mammogram and USD. USG is preferred for pregnant, lactating, young females of less than 30 years, and mammography for the rest of the females. If the lump is present, assess whether it is benign or there is a suspicion of malignancy. And we have if we have a benign findings in USG or mammogram, do USD. If the lump is not present in mammogram or in mammogram, then also do a USD. Then assess whether the lump is benign or suspicions of malignancy. And if the lump is present, also assess whether the lump is benign or there is a suspicion of malignancy. If the lump is not there, reassure the patient and tell her to follow up after 1 year. And the patient is complaining of lump, and if we are not able to make out in USG or mammogram, order a true cut biopsy. Then even though it is not present in mammogram or USD, then if there is a suspicion of malignancy, also do true cut biopsy. True cut biopsy is the investigation of choice or the most appropriate step in a patient with complaints of lump in the breast. Okay, then coming to varicose vein. So next topic is varicose vein. So varicose vein is defined as elongated, dilated, tortuous, superficial veins of the lower limb due to valvular incompetence. It is most common in women, and the risk factors are prolonged standing, obesity, pregnancy, and family history. The etiology can be due to congenital vein wall or valve weakness, and secondary varicose veins are due to deep vein thrombosis, obstruction, or AV fistula. Then the pathophysiology is valve incompetence, which causes venous reflex. Then this reflex will lead to venous hypertension and vein dilation. This pathophysiology was earlier asked in Kerala PSC. So the patient will present with visible tortuous vein, aching and heaviness which worsen on stanting, and there will be edema, skin pigmentation, eczema, and ulceration. The complications will be bleeding, thrombophlebitis, varicose eczema, and venous ulcer at the gaiter area. Investigation, we can do Trendelenburg test to assess the saphenofemoral junction incompetence, Perthes test to assess the deep vein patency, and duplex ultrasound, which is the gold standard investigation. Then coming to CEAP classification, which is very important, and it has been asking, it will keep on asking for NEET PG. So just revise it. CO means no invisible or palpable signs. C1 is telangiectasia or reticular vein. C2 is varicose vein. C3 is edema without skin changes. C4A, it is pigmentation or eczema. C4B is lipodermal dermatosclerosis or atrophy blanche, which is a previous year question. So C4B is lipodermatosclerosis or atrophy blanche. Then C5 is healed venous ulcer. C6 is active venous ulcer. Then coming to E, EC means congenital, EP means primary valve incompetence, ES means secondary valve incompetence due to DVT or obstruction. EN means no identifiable cause. AS is superficial vein, AP is perforator veins, AD is deep veins, AN is no venous location identified. Then coming to P, PR means reflex, PO means obstruction, PRO means both there is reflex and obstruction. So this is the CEAP classification. There is an ABC grading, you can ignore it. The treatment is compression stockings, limb elevation, exercises. Then we can do sclerotherapy, endovenous, laser ablation, radiofrequency ablation. The treatment is Trendelenburg operation, vein stripping, and perforator ligation. The prognosis is good with early treatment, and in untreated cases, they may ulcerate. The most common site is long saphenous vein. Venous ulcer location is gator area. Trendelenburg and Perthes test are classical exam questions, so go through it. Detailed CEEP classification is very important, and surgical treatment is Trendelenburg operation with vein stripping. Then this is for today. So Baki, I will rest of the topics I will discuss in next classes. So meanwhile, download the notes. I have provided the link to download the notes and start studying. Okay, me. So see you in another class. Thank you.